I know that lactated ringers and normal saline are both isotonic solutions, but is there really a difference between them? Is one better than the other?
Alrighty, Christina, buckle up. We're about to go on a crazy journey to explore the exciting world of primary IV solutions, specifically normal saline and lactated ringers. We all talked about using them for different reasons and how it basically just depends on policy as to which one would be used. But is there one that is superior that should be used as a standard go-to primary solution? Well, yes, actually there is. It seems there is a superior primary IV solution that many disorders would benefit from. So let's talk about these two solutions are in general, then dive into disease processes that benefit from one specific solution. All right, Christina, you're going to be able to differentiate lactated ringers from normal saline, discuss the risk of hyperkalemia, especially in renal failure patients, based on different solutions used, identify which fluid is more helpful in the inflammatory response and can help reduce inflammatory processes such as that in acute pancreatitis, explain which fluid is more beneficial with fluid resuscitation and is more beneficial during diseases like hypovolemic shock, hemorrhage, and burns, which requires higher volumes of fluids, identify which IV solutions is superior when giving blood and blood products based on patient outcome, and you'll be able to learn to advocate for their patients with the help and knowledge learned to provide the best IV solution possible. So, before we talk about normal saline and lactated ringers, we should first talk about what isotonic solutions are and how they work inside the body with the use of this video.
When two solutions, separated by a semi-permeable membrane, have equal concentrations of solutes and water. Imagine you're at a party and there are an equal number of guests in the living room and in the kitchen. It doesn't make much of a difference where you stand because you are equally as comfortable in either room. You have just as much space, you can move just as easily, and you have equal access to food. You don't spend a lot of energy trying to get out of one room or into another. This party is like an isotonic solution. Everything is equal from room to room. Now, compare this with a party where the living room is packed full of guests, while there are only a few in the kitchen. I don't know about you, but I would be trying to get to the kitchen as fast as possible. The concentration in each room is different, so people are moving around trying to equal things out. Nature likes equality, and that is apparent when it comes to solutions.
Tonight it is necessary to talk about each fluid independently. So, what is normal saline? So, normal saline is an isotonic solution composed of water and sodium. The osmolarity of it is similar to serum plasma. As Tanog talks about normal saline, it is a primary fluid used with hydration, electrolyte replacement, and it's the only fluid that can be used in the same intravenous line as blood, whereas lactated ringers will need to be given through a separate line to prevent a reaction. The biggest reason that Tanog mentions as a contraindication of the use of normal saline are overhydration, heart failure, impaired kidney function, and it's a high risk for fluid overload. So this will be the time that we would be assessing those lung sounds.
So now we're going to talk about lactated ringers. So what are lactated ringers made of? It's made of sodium, chloride, potassium, calcium, and lactate. So according to an article by Singh on lactated ringers, what they do are they buffer imbalanced solutions. They're also used for aggressive fluid resuscitation. So some examples of that include blood loss, burns, sepsis, and inflammatory processes like acute pancreatitis. So some contraindications for lactated ringers would include overhydration and liver dysfunction. So since overhydration is also a complication for this, you also might have to give diuretics because you want to make sure the fluid is going in the right space. So if it's in the extravascular space, that doesn't help the patient and you might need to give diuretics. A couple myths that come with lactated ringers. They used to believe that lactated ringers increase your risk for hyperkalemia because it has potassium in it. and also that it worsens lactic acidosis because it has lactate in it, and that has now been disproven that that is not true.
So lactated ringers don't cause hyperkalemia.
No, they actually don't. Back in the day, they used to think that lactated ringers cause hyperkalemia due to the fluid containing some potassium. They also used to use normal saline because of the potassium as well. According to an article in CHAM in 2015, a nationwide survey of 49 hospitals revealed that in 90% of all renal transplantation cases, normal saline was used in order to avoid a hyperkalemic state that was associated with potassium-containing fluids such as lactated ringers. However, as CHAM continued to talk about the research, he talks about a double-blind study that resulted in normal saline actually having higher rates of hyperkalemia as well as metabolic acidosis in comparison to lactated ringers in chronic renal failure patients. The study shows that it's important to look at the patient as a whole and the reaction to certain medications within the body instead of simply looking at the components that make up medication and fluids. CHAM in 2015 also talks about how lactated ringers are more commonly preferred over normal saline with renal transplantation. There's a decreased risk for hyperkalemia with the use of lactated ringers, as well as many other benefits.
In clinicals, my patient was admitted for pancreatitis. I wonder what solution he got.
That's a great question, Christina, and I was just getting to that. Behold, a pancreas. A healthy pancreas versus an inflamed pancreas. With the help of lactated ringers, you can get your pancreas from this to this, and I'll tell you why. According to Iqbal, he states that C-reactive protein, which is a nonspecific inflammatory marker, is dramatically lowered within 24 to 48 hours of infusion of lactated ringers. This is due to the anti-inflammatory properties that lactated ringer has. Another factor of lactated ringers is that it is an alkalotic solution versus, say, normal saline, which is a little more acidotic. An acidotic solution can lead to inflammation as well as necrosis. So, Christina, this is the part that you want to be listening in on. He stated that a study was conducted basically looking at people who suffer from acute pancreatitis who are also getting an infusion of lactated ringers. What they found was that people who had lactated ringers had less complications such as systemic inflammatory disease, as well as a decrease in the mortality rate. This is a very important finding, and all healthcare providers should be made aware of this. Another benefit is because it has anti-inflammatory properties, this means that you need less anti-inflammatory medication. Less anti-inflammatory medication leads to less medication-induced side effects.
So, for large volume infusions and fluid resuscitation, would you use lactated ringers or normal saline?
Great question. So some scenarios where we may need large amounts of fluid resuscitation include hemorrhagic or hypovolemic shock, as well as burns, just to name a few. According to Martini's 2013 study, lactated ringers are found to be a better fluid compared to normal saline when it comes to fluid resuscitation. While both fluids have equivalent hemodynamic and oxygen metabolism, there are some important differences to note. Normal saline has vasodilating effects. Well, what does this mean? If our patient comes in with hypovolemic or hemorrhagic shock, we can expect their blood pressure to be down because that is a hallmark sign of shock. And if we use normal saline, we run the risk of decreasing their blood pressure even further, causing them to bottom out, and we do not want that at all for our patient. Normal saline also has an increased risk for hyperkalemia. As the prudent nurse, we must know that anytime there are abnormal potassium levels, meaning less than 3.5 or greater than 5, we are on the lookout for life-threatening arrhythmias. In burns, we know that when cells get destroyed, potassium is released, causing hyperkalemia. Again, we would not want to increase their potassium even further, which is a possibility with normal saline. Moving on, according to Iqbal's 2018 study, large amounts of normal saline can cause hyperchloremic metabolic acidosis. This happens when there's an overload of chloride ions that forces bicarbonate to move intracellularly as a way of maintaining ionic homeostasis in the body. Of course, we understand how this happens. Another name for normal saline is sodium chloride. So we are essentially filling them with chloride ions, which would lead to this hyperchloremic metabolic acidosis.
What are some signs to look for so that I know that my patient is in metabolic acidosis?
As you can see in this wonderful visual from Google, it lists some signs that we can expect to see in a patient dealing with metabolic acidosis. The list includes having a headache, decreased blood pressure, hyperkalemia, muscle twitching, warm flushed skin, nausea, vomiting, diarrhea, changes in level of consciousness like confusion and increased drowsiness, and Kussmaul respirations, which is a hallmark sign of metabolic acidosis. This could lead to coma, arrhythmias, and cardiac arrests. Lactated ringers would greatly help prevent many of these complications, thus making it the superior fluid for fluid resuscitation. But what if our patient is in need of blood?
So, you mean fluids as in blood? Is blood a fluid?
I can help you with that question. All blood products are fluids, but all fluids are not blood products. Normal saline is commonly used with blood due to the compatibility properties between the two. As Waters explains within a research group, lactated ringers has a slightly higher coagulation risk than normal saline. Research has also showed that normal saline has been found to increase the need for fresh frozen plasma as well as increase the need for volume for platelet transfusions. Overall, it's increasing the use of all these blood products. This is due primarily because of the acid-base differences between the two. With the factors I just mentioned, it's clear that lactated ringers should be the primary fluid when infusing medications, as well as large blood loss volume procedures to prevent the need for more blood products in the long run. Doing this will also decrease the risk for blood transfusion reactions to occur. Although lactated ringers cannot be infused in the same line as blood, it is also proven to be the most superior primary fluid to be infused.
So, if I were to see this topic on a nursing exam, what do you think the question would ask me?
Awesome question, Christina. I actually created a practice question to help you with this. A nurse was preparing to administer a patient's intravenous fluids. The patient was admitted 1 hour ago with scleroderma, an inflammatory autoimmune disease. Based on the patient's diagnosis, the nurse is going to administer which of the following solutions? A. Normal saline. B. Lactated ringers. C. 5% dextrose and water. Or D. 0.45% normal saline. Drum roll, please. The correct answer is B. Lactated ringers. As we talked about earlier, multiple studies show that C-reactive protein, a nonspecific inflammatory marker, has been shown to significantly decrease within 24 to 48 hours of administration of lactated ringers. This is due to the anti-inflammatory properties that lactated ringers has. Because this patient has an inflammatory disease, lactated ringers would be a great choice in an attempt to decrease inflammation. Another reason that lactated ringers is the correct answer is because lactated ringers also has a more alkalotic pH than normal saline does. Acidosis enhances inflammation and necrosis, so we would want to give a more alkalotic solution with this patient. Does this help you?
Okay, that makes a lot of sense. I think I got it now. Normal saline and lactated ringers aren't as similar as we previously thought. Their different components actually change when they're used. Normal saline will be beneficial a few times, but lactated ringers have shown to have a better outcome. Lactated ringers are less associated with hyperkalemia than normal saline, especially with renal failure, which already have metabolic issues. Lactated ringers also have anti-inflammatory properties that normal saline doesn't, which contributes to the use of lactated ringers in acute pancreatitis. Lactated ringers have favorable outcomes with large fluid resuscitation, such as hypovolemic shock, burns, and hemorrhage. Lactated ringers are not used
with blood and blood products, although the studies have shown that the body needs less of these products when using lactated ringers versus normal saline. Now we can all make better isotonic choices as the educated nurse to help and advocate for our patients.
Yes, Christina, so now you'll have no problem identifying and being able to answer all of these objectives. And I'm going to go over them one last time just to make sure. So, were you able to differentiate lactated ringers from normal saline? How about discuss the risk of hyperkalemia, especially in renal failure patients, based on the different solution used? Were you able to identify which fluid is more helpful in the inflammatory response and can help reduce inflammatory processes, such as that of acute pancreatitis? How about explain which fluid is more beneficial with fluid resuscitation and is more beneficial during diseases like hypovolemic shock, hemorrhage, and burns, which requires higher volumes of fluid? Identify which fluid IV solution is superior when giving blood and blood products based on patient outcome. And are you now able to advocate for your patient with the help and knowledge learned to provide the best IV solution possible? I think I'd say so. Luckily, we were able to find and use all these different amazing resources to be able to increase our knowledge on lactated ringers and normal saline and find out which would be the best solution to advocate for our patients to get the best care possible.